So this section is on colic. Before we learn to understand about colic, it's important to understand what to expect in the first few months of parenthood. The first few months of parenting are particularly tough as you take on the full responsibility of a precious and needy little baby and have to function on minimal sleep. My advice, accept all the help you can get, don't set your expectations too high, and don't expect your baby to fit into a mold. This is survival time for all, and the enjoyment of parenthood will come over time. For the first 3 to 4 months of life, a baby's brain and a baby's gush are both still very immature. This time has been dubbed the 4th trimester. Most babies have gripes and groans during the first 3 to 4 months. A baby is also not yet able to manipulate you during this time, hence feel reassured that it is not really possible to spoil a baby during the first 3 to 4 months. Also remember that it is normal for a baby to cry, as it's its only way of communicating. Crying increases from an average of about 1 hour a day at birth and peaks at 2 to 3 hours a day at 6 weeks, then gradually increases again to 1 or 2 hours a day at 3 months of age. I call this the crying curve. Remember the crying curve when you're tearing your hair out at 6 weeks post-birth, because the child is at its peak in crying at this stage. So with these facts as a background, let's now talk about colic. The term colic is used rather broadly by doctors and parents and patients to indicate prolonged excessive periods of crying and unsettledness for no apparent reason in the first few months of life. We use the rule of 3 to define colic, referring to crying that lasts for more than 3 hours a day, more than 3 days a week, and persisting for longer than 3 weeks in a child which is growing normally. The crying episodes in colic are usually of abrupt onset, often clustering in the early evenings. The cry is more intense and high-pitched than a normal cry, with a piercing and often grating quality. Now, the perception or expectation of parents certainly plays a role in defining a child as colicky. It's important for parents to understand the normal pattern of crying which we have described. Colic goes beyond the normal crying, and the persistent or excessive crying is really distressing for the baby, for the parents, and even for the healthcare workers involved. However, as mentioned, by definition, a colicky baby is thriving and developmentally normal. So who gets colic? Colic is common. It occurs in up to 40% of babies. It occurs equally amongst males and females, firstborns and subsequent children, breastfed and formula-fed babies, and there's no good evidence for an increase after a cesarean section, so anybody can get it. It can run in families, and it does seem more common in societies in which expectations for babies are perhaps a little bit higher. What causes colic? Well, there are many theories as to the causation of colic, but no one actually knows. There's no overriding evidence for any of the theories. It probably represents a combination of an immature gut and an immature brain. Colic may well be a final common pathway for many factors, including one or more of the following. So immaturity of the gut, as we mentioned, can contribute. Hypersensitivity to environmental stimuli, leading to a baby to really cry it out in the early evening to offload, may be a factor. An abnormal movement of the gut or motility issues can contribute. Trapped wind can certainly play a role. Feeding difficulties can contribute, such as feeding too much or feeding too little, in which case the child will be hungry, swallowing too much air, having too much foremilk. Infant temperament, family stress, and emotional tension during pregnancy may also contribute to make a more colicky baby. Exposure to tobacco smoke in pregnancy and after birth is certainly a contributing factor. Disturbances of the bacteria of the gut can also play a role. In a small percentage of children, pathological factors can play a role, such as reflux of stomach contents into the esophagus, cow's milk protein allergy, or lactose intolerance, which is an inability to digest all the sugar in breast or formula milk. But this is in a tiny proportion of patients. How do we manage colic? The first thing to say is that symptoms usually resolve rather abruptly in 60% of 3-month-olds and 90% of 4-month-olds. So there is light at the end of the tunnel. Families dealing with colicky children need to be reassured that no harm will come to baby in the long term. Management needs to be individualized according to the characteristics of the baby and the family to help the parents to cope with the child's symptoms. In all cases, in a colicky child, the child should be examined thoroughly to rule out other causes of pain or irritability, such as an ear infection or fractures, for example. The parents should be reassured that colic has nothing to do with their parenting abilities. It can happen to anybody, and the difficulty that a colicky baby brings to a family should be acknowledged. Parents should be reassured the colic will eventually be outgrown, and as mentioned, the child will come to no long-term harm as a result of the colic. A number of management or coping strategies are available to manage colic, but most are of unproven benefit. It's also important to know that each child responds differently to different strategies, depending on their main cluster of causes of their colic. And most individual strategies work in only about 1/3 of patients. So the important thing is that the strategies are as safe as possible. Certain colic mixtures, certain antispasmodic drugs, for example, have been associated with harm to the baby, so should best be avoided. So management strategies include the following. First of all, parental support. This is the time to get family and friends to come and help, if only to give the parents a quick break from the stress of crying. If the mother is feeling at the end of her tether, she should rather leave the baby safely in a cot and have a quick break rather than running the risk of harming the baby. Changing feeding techniques may help. For example, in a bottle-fed baby, sitting them more upright during feeds or changing the bottle to an anti-colic one may help reduce the wind intake. In breastfed babies, emptying one breast completely during each feeding block may reduce the intake of lactose from the foremilk. Carrying the baby during crying spells usually helps, especially also in an upright baby carrier. Gentle swaddling may help to contain the baby. Regular motion, such as a ride in a car or a safe baby swing, may help to calm the baby down, and white noise, such as the sound of a washing machine or a radio, sometimes helps. A warm bath or a baby massage can go a long way in calming a baby. A dummy or pacifier may be of help and can be used a few weeks of age once feeding has been established. If the baby is breastfed, a mother may try to cut out dairy and caffeine from her diet, but only for a week in the first instance. If it makes no difference, please go back to your regular diet. Some practitioners advise mothers to cut out other highly allergenic foods such as wheat and eggs and nuts, but there's not much evidence for this. Cutting out gassy foods, gas-forming foods like onions or cauliflower or spicy food or citrus may help, but once again, the mother should abandon this diet if there's no response after a week or two. Life is certainly tough enough without having to follow a strict diet, and the breast milk already sorts out a lot of the food which gets to the baby. The lactase enzyme is responsible for breaking down lactose, which is the sugar in breast as well as formula milk, and sometimes supplementing with a lactase enzyme can help a colicky baby. Using wind drops containing the ingredient simethicone may help to break winds down a little bit more easily, but doesn't have a good track record yet in colic. Antispasmodic medications and homeopathic medications should please be used sparingly, as they could have a side effect. Certain herbal ingredients such as fennel or chamomile may be tried in small quantities. In some cases, chiropractors or craniosacral therapists may gently manipulate the bones to ease colic or constipation, but once again, we don't have much evidence to back this up. Similarly, baby massage may help to relax the baby and ease the tummy gripes. If symptoms are suggestive of severe acid reflux, such as excessive vomiting, excessive pain associated with feeding, feed refusal, then a trial of anti-acid medication may be given. This trial should be short and under medical supervision. Antacids are used far too much and can cause side effects in the baby, so a baby really has to deserve them. In severe colic, in a formula-fed baby, a 1-week or 2-week trial of a broken down cow's milk formula should be tried to make sure that this is not a cow's milk protein allergy. But please consult your healthcare practitioner to suggest a suitable formula. Once again, if this makes no difference after 2 to 3 weeks, rather go back to the baby's regular formula, which is less costly. In some cases, healthcare practitioners may suggest soya milk, but remember that cow's milk and soya have an overlap of at least 50% in real allergies. More potent colic mixtures can be sedating. They can have side effects, so they should be used very, very sparingly in crisis times only and after discussion with your doctor or clinic sister. Remember that individual colic medications don't have a great track record, don't have a great success rate, and work in only a third of patients. Therefore, in general, if they don't make a difference after a week or two, rather stop them. Time is a great healer in colic, but it is sometimes hard to accept when you have a little baby crying 24 hours a day. So when do you worry? When could this be more than colic? By definition, colicky babies are thriving and developmentally normal. But parents should seek medical attention under the following circumstances. Firstly, if crying is truly excessive, more than 4 or 5 hours a day, the child is screaming all the time, rather have them seen. This may be reflux. Secondly, if the child is not gaining adequate weight, they should be seen. Thirdly, if there's a persistently runny tummy or blood or mucus in the stools, a child should be seen to rule out an allergy. If stools are frothy and green, a lactose intolerance has to be ruled out. And if there's excessive pain on feeding, feed refusal, back arching, reflux disease needs to be ruled out. A quick mention of vomiting. Most babies are vomity. They have an immature valve at the top of their stomachs which lets milk go down and then come up again. This is normal. Vomiting, in fact, only peaks at 4 months of age, so can get worse before it gets better. However, if the vomiting seems excessively painful, associated with back arching and a refusal to lie down, with an extremely miserable child that fusses during feeds, then reflux disease should be considered and discussed with your healthcare practitioner. Let's summarize. When do we worry about colic? First of all, with excessive vomiting, remember that painless vomiting is normal and peaks at 4 months. If there's inadequate weight gain, if there's extreme or constant crying, if there's refusal to feed, if the baby is chesty, if there's a severe nappy rash, if there's persistent diarrhea or very runny green frothy stool, if there's blood or mucus in the stool.